Welcome to today's webinar, Pharmacology Challenges in the Pre-Hospital Setting. We are excited to welcome our presenters, Dr. Stein, Bronsky, and Mark Warth. We appreciate everyone taking the time to join us today. We will be turning the webinar over to Mark shortly, but first we want to share some webinar tips. NEMT would like to recognize our sponsor for today's webinar. On behalf of NEMT, we extend a warm thank you to iSimulate. We thank iSimulate for their continued support in advancing the EMS profession and caring for our nation's EMTs and paramedics. It is NEMT's pleasure to introduce today's presenters, Dr. Stein Bronsky and Mark Warth. E. Stein Bronsky, MD, is the Medical Director for the Colorado Springs Fire Department and American Medical Response Ambulance Service in El Paso County, Colorado. He also works as an emergency physician at Centura Health. Dr. Bronsky began his career as an EMT in 1991 and later practiced for several years as a paramedic before attending medical school at Vanderbilt University. He completed his emergency medicine residency and EMS fellowship at Virginia. Our other presenter is Mark Warth, NRP. Mark has been involved with EMS for more than 20 years, beginning his career in 1997 as a volunteer EMT for a rural ambulance service. He quickly advanced to the EMT intermediate level. In 2001, he completed the paramedic program at the University of Colorado in Colorado Springs. Since then, Mark has worked for various types of EMS entities, including hospital, county, fire, as well as private agencies across Colorado within the rural, suburban, and urban settings. In addition to EMS, he holds a bachelor's degree in health science and has been educating for well over 15 years. Currently, he is the medical program coordinator for Colorado Springs Fire Department, one of the busiest systems in Colorado. His duties include being an EMS liaison, providing monthly CE classes for his local agencies, renewal courses, and EMS PI program management. In addition, Mark assists other faculty in lecture, lab, training academies, and curriculum development. Welcome, Dr. Bronsky and Mark. I now turn the presentation over to you, Mark.
Thank you. We're actually really excited to present this topic. This came about by kind of a roundabout process of taking a new look at pharmacology and pharmacology practice. And what we're going to talk about today on this lecture is we're going to talk about some statistics, epidemiology. We're going to look at defining what an error is. We're going to look at some rights, things that traditionally we've looked in the past, and then what's coming down in the near future, and what's best practice for our patients. In the end, we'll talk about the management of medications, especially during some shortages that we might be seeing here in the next, few months to a year. That being said, we actually took a step back, and when we looked at an approach to do this chapter in the book, in the AMLS book, we wanted to look at a different philosophy. And that philosophy was quite simple. We didn't want to do the traditional framework of content that looked at, side effects, contraindications, dosages, and other. What we really wanted to look at was where mistakes were being made and how can we mitigate and avoid those mistakes. So we took a philosophy and we looked at knowledge, right? So the first thing we want to look at is where's the clinical judgment, where's the clinical thinking, and what kind of skill acquisition do we have? And that is always in odds in our care to see which one's going to take over at the time. Some of us have more clinical judgment because of experience, some of us have more clinical thinking because of knowledge, and some have higher skill level based on level of care. Then we looked at decision, and that decision making comes from critical thinking. And that's really about cost-benefit analysis. So how are we looking at the cost of this medication versus the benefit versus what we're going to see as a side effect? Is this the right time to do this and deliver this medication in the right situation? And in the end, what we really want to look at was responsibility. In the end, we're responsible as clinicians to practice safe medication administration. In that, we have to have accountability. And that's one of the biggest things we want to focus on is safe practice and accountability, and where does that land with us when we talk about medication and pharmacology pitfalls. So the first question we want to ask, and we ask everybody and we ask ourselves, is how many steps are there to medication administration? So if you had a guess, and there's a poll that's going to pop up, how many steps do you believe is available to you for medication administration? Is it 5? Is it 6? Is it 10? Is it 20? If we don't know how many steps there are, then we don't know what the endpoint is. And that is what helps determine whether an error is going to be created or not. So that being said, answer this little poll and ask yourselves, well, how many steps are there to medication administration? We'll give a few minutes. Good, I see answers coming in. And we're seeing of various different amounts. So we have less than 5, 6 to 10, greater than 10. And the vast majority are saying right about 6 to 10. About 70% of you are answering that. about 17% greater than 10. In reality, there's actually 10 to 20 steps. Depending on the complexity of the medication, really depends on how many steps. But it's our job when we're talking about administration medication to make sure we ensure the safe and effective practice of medication administration, including the compliance of guidelines, protocols, and practice. It is difficult enough that we have to deal with this side of actual practice with medication administration, but we also have other aspects of medication administration, like environment, right? And so we have these challenges that are put in place in the pre-hospital realm versus the hospital setting that we have to be aware of. But first and foremost, 10 to 20 steps, guys, that's a lot. The more steps we add, the more avenue for potential errors. And we got to be very careful about that. And when we look at moving forward, once we identify how many steps there are, we can now identify a terminal point to make sure that there's an action to ensure the efficacy and compliance of medication administration. This is what we learned from our mistakes, right? In the past, when we look at medication errors, we went and looked at how many steps were made and how many mistakes are potentially available. When we look at this, this is why it's so important to understand our mistakes. Let's look at numbers. Let's get statistics and epidemiology. Let's take a step back, broad picture view, 10,000 foot view, and let's look at some numbers. So when I say how many medications or errors are done a year, 1.5 annually. In a year, a medication error is reported. It's the #1 medical error in all of medicine, guys. #1, over 400,000 hospitals reported errors in medication administration. It costs $3 billion a year because of these errors. It's the 3rd leading cause of death. When you look at 400 deaths a year, it's 400,000 deaths a year, guys. Number 3 in the 3rd leading cause of death in the United States, if we put that in perspective. So when we look at these numbers and we evaluate them, the question that we came up is, well, we're doing the 5 rights, right?
Yep.
We do the 6 rights, 7, whichever one we come up with. If we're doing the 5 rights and it's working, and we're doing this traditional indications, contraindications, side effects, checking the route, checking the expiration date, and all this is occurring, the question I would ask everyone that's listening today is, if traditionally that was working, how come we're seeing so many deaths a year and so many errors a year, and that is not on the decrease, that is on the increase? And that was the foundational question we asked ourselves when we got ready to write this chapter and design this lecture, was if it works, then we shouldn't be seeing this, but we are. So when you look at this, self-reflection is our greatest tool as human beings. Being able to look big picture and see what we are doing now as compared and project in the future and how we can improve ourselves is the best tool we have as human beings. I love this quote from John Dewey. John Dewey was an American philosopher, and he was really big in educational reforming. And he was a reformer trying to understand how we improve the system. The only way we can improve the system is by evaluating current practice and then make the hard decision to ask ourselves, is it working? And make an even harder decision to say, you know what, it's not, we need to change it. So we do not learn from experiences. We learn from reflecting on experiences. And that's really what we want to do with medication administration. So let's look at some more numbers. We have to ask ourselves, what's pre-hospital do? So in a study done in 2007, 9.1% of a large agency reported committing an error. So that means 90% of the time they did things correctly, or they just didn't report it, either by omission or commission. What we have to look at now is 63% of those errors that were reported were dose related, and this is going to be really important later. 33% were protocol related. Why it's really important to reevaluate your guidelines and protocols at a minimum of once a year, twice a year if you can, to ensure that the guidelines and practice that we follow are up to date in standards, because as you know, doses and medications change based on shortage, which Dr. Bronsky is going to talk about later. 21% were route related, and then 4% were related to appropriateness. So when we look at appropriateness of medication, what that means is 96% of the time we're choosing the right drug for the right situation. So we know what we're doing with the medication. Where the error lies is the dose. That's the biggest issue. 4% of these errors were actually found in the quality assurance and quality improvement process. Only 4%. So when you look at this, if you're relying on your CQI team to find these errors, mistakes, and procedures in medication administration, we're looking at the wrong side. 4% were actually found and reported in the CQI process. That means the vast other ones were either done by either self-reporting or when we looked at it, there were actually complaints that were filed. So we have to look at how we bolster and fix that. If our CQI team's not finding it, then we got to find it way before it's ever reported or found in other situations. So some contributing factors that they found in this study was a failure to do a triple check or a double check, either one of those. Infrequent use of medication. Well, that makes sense. If I only do adenosine and administer it once a year, I'm not going to be familiar with it. So that infrequent use is a contributing aspect to medication administration errors. Dosage calculation error was one of the biggest contributing factors to medication administration. That coincides with 63% were dose related. Now I look at the actual process of moving forward. They did other studies in 2012 and 2006. In 2012, they found researchers confirmed that the prevalence, when they looked at medication administration in patients who arrived in the emergency department by ambulance, they found that 12.7% of incidence of medications errors, particularly in patients who revived or received more than one medication. So if we give more than one medication, it's going to increase the likelihood and chances of errors. In another study in 2009 in Michigan, they found that pediatric dose administrations of epinephrine were astoundingly off. And actually, these medications occurred in almost 40% of children who were given a medication that were weight were recorded, meaning we recorded the weight and we still got the dosage wrong. So looking at this, we have to understand that there are errors that have occurred, and there have been studies done to show that those errors continue to happen. So we have to take a step back. I always use the analogy when I jump a river. If I have to jump a river, the wider the river or the creek bed, the longer steps I got to take back. So we got a big issue in medication administration in the pre-hospital world. So we have to take a real big step back and reinvent and reevaluate the process, because what we're currently doing is not working. So is there a better way? That's the question we have to ask. So here's another poll. The question I want to ask you guys is, in that only 9% of patients or providers actually reported an error, only 9%. So the question I ask you is, why do you think only 9% of individuals actually reported an error?
And to clarify, this would be the people who knew that they made an error and chose to or not to report it.
Correct. So we're getting some results. What are we getting? Looks like about 49% is fear. The other one is fear of lawsuit, and the other one is fear of being reprimanded. Absolutely. And that's kind of the trend we want to identify. Fear is a driving force, and fear leads us to things that ends up being hiding or lying. And it's a natural process that humans will do. Lying is one of those things that is a natural occurrence to avoid conflict. And so if I'm fearful of losing my job or reprimand, or fear of any kind of altercation from a mistake that I made, and 100% most of the time, we're not looking to do harm. It's just an error that happens, most likely due to the system issue, protocols and guidelines. We still feel responsible for that, and we have a fear of looking at this and understanding, hey, we got a big issue. So now moving forward, we have to say to ourselves, okay, if fear is our driving force of reporting, we have to remove the fear. And we got to say, hey, for safe reporting, one of those foundations that we got to understand is that we got to take away fear. Take away fear, reporting becomes a little bit clearer. The next thing I want to ask you guys, what are some issues that we face that contribute to errors? So if we have mistakes that occur, whether we report or not, what are some ideas that you think contribute to those errors? We identified some of them in the previous slide. What are some things that you can come up with that will contribute to medication errors?
And it looks like already, as these results are coming in, that the far majority percentage, well, they're evening out a little bit, but still the highest percentage is exactly what we thought, which is math.
Math. And that's going to really come to play here in a second. But math is a big one. What other ones do we have, Stein?
Yeah, so in order of how everybody has answered in the poll, math is first, difficult environment is second.
Yep.
Failure to check the rights is the third. Poor lighting did get a little bit, 25% of people answered that. And there was 1% that said unsure.
Unsure.
But really those three factors of it being a very austere, uncontrolled environment, a lot happening, trying to figure things out on the fly, maybe the time of day also, or middle of the night. And then all that compounded with do a complex math calculation right now.
Yeah, 3 o'clock in the morning. So now This goes along to what we found with our research. Poor lighting was one of them. That was a big complaint that providers had when it came to contributing errors. Difficult environments, absolutely spot on. When we looked at environments, we deal with a dynamic, ever-changing environment. Outside, inside, cold, hot, dry, humid. We've all had those on those humid days where that vial just doesn't stay in our hands and it kept slipping out of our hands. These are all things that we have to deal with. Family members, loud noises, generators going, engines, apparatus, all things that contribute to stressors that decrease the ability to critical think through a situation and gets more emotional versus logical. Now we look at inadequate staffing. That's a big one. And I think everyone can attest that across the nation in EMS, we have some inadequate staffing that's going on. I have to work more higher back, mandatory higher backs. We work 3 shifts in a row. By the time I get to the 3rd shift and my 50th call, my brain's not functioning like it should. Those all are contributing factors to what we deal with every single day. If you really want a good idea of how and when medications occur, start tracking that. If the vast majority of our medications errors and procedural errors are happening on the end of the shift versus the beginning of the shift, are they on busier shifts? What station and what house is it happening at? These are analytics you can start pulling to help determine, is it a staffing issue that's contributing to the medication error? Too easy do we just say it's the provider's fault to say that's why they made the error. We have to get outside and past the fact that it's the provider. Ultimately, it's the system. It takes a village to correctly administer a medication safely and effectively. Long hours is a big one. Long hours, I think everyone can attest to that. Ever-changing concentrations. What do you think about that, Stein?
Well, as we'll talk about a little bit more with shortages, is that there isn't a consistency in the way that medications are produced. And so you'll end up with medications that all of a sudden are a certain strength or concentration one day, and the next day it's different. Your muscle memory and your brain memory tells you to do one thing where you need to be doing something else.
Yep. And next thing you know, we give an overdose of a narcotic, and we give 100 milligrams as opposed to 30, and our patient's in respiratory arrest. But technically we're supposed to do our 5 rights.
Yep.
Right? Okay, so looking at the trailing zeros was number. If you like to do math and you do math on a piece of paper and you're like me and I can barely read what I write on a good day, that trailing zero becomes a problem. And so instead of giving 2 milligrams, I give 20.
Yep. The decimal points are definitely one of the largest errors. It's less common to have I gave 30 milligrams instead of 60. It's more common to say, that was supposed to be 0.2,
yep,
not 2.0.
Right. As we look forward, we look at ambiguous drug labels. That's I find myself getting older. It's getting harder and harder to read these labels. They get smaller and smaller. So looking at these ambiguous drug labels, that becomes problematic. Lack of effective independent double check system. I'm going to really spend some time on that later. That is one of the things that are far and beyond, far stronger than doing your right evaluation. And I'll prove that to you here in a little bit. The last thing we're going to talk about is math. Remember what I said earlier about self-reflection. It's time to look at ourselves and go, are we really good at math? As a system, as a society, as a unit. And some people are really, really good at math. I was a math major. I loved it when I was going to college and high school. And then I started taking advanced calculus and all the numbers disappeared. And I was like, where'd the math go? So dimensional analysis is really important. Dimensional analysis is defined as the method that sets up a relationship to calculate drips, rates, and or weight-based calculations. That is all predicated on whether or not we calculate the weight correctly. So if we had a small poll and we asked somebody, hey, Stein, how much do you think I weigh? And vice versa, how accurate are we going to be?
So as we're doing that, I just want to reiterate to everybody that a lot of organizations may feel as though they don't have very many medication errors. And I would challenge everybody to look at your system and understand why it is that you think that. Is that actually what's happening, or is that what is being reported? Or is that due to some system changes and advancements that you have made in the way that your organization works in order to systematically cut down on the amount of medication errors?
That being said, we're going to get back to math. And PISA, we talked about weight-based calculations. And PISA, which is the Program for International Student Assessment, is a large group that evaluates how well we are in certain topics in school. One of those is math. And right now in the United States, we as a society are ranked 36 in the world in industrialized nations in math. We averaged an 11-point drop in 2016. there are contributing factors to this. And when we give this statistic, everyone gets a little upset about it because it's like, oh yeah, I can do math, and we can. There are certain amounts. We have to understand we're getting more and more reliant on technology. We're getting more and more less functional with dimensional analysis and evaluation at 3 o'clock in the morning, because the last time we did an algebraic equation consistently was probably high school or college, and we're now 20 years into our careers. And we're asking you in a critical event to calculate a critical medication at a critical time in your 50th call at 3 o'clock in the morning. And this is why drug errors and mistakes, especially when it comes to dosing, has increased over time. Is we keep trying to put a square peg in a round hole. We keep trying to continue to do this in a way that it unfortunately is just not working. So one of the answers that we looked at was, hey, what about standardized dosing? You guys do that in the hospital, don't you?
A lot of times we do.
Yeah.
Absolutely.
So looking at this, is standardized dosing a way to mitigate those errors? Let's remove the calculation altogether and go to that standardized calculation and dosaging. And one of the things that we did in our system right away was we removed weight-based calculations, and that dosage error predominantly went away. We still get medication errors, don't get me wrong, that does happen, it does occur, wrong situations, etc. But for the most part, when our talks about our dosaging gets a lot easier to deal with when I don't have to take that calculation into play. They did this in the study with pediatric administration narcotics, and they found that the vast majority of the time, pediatrics who needed a narcotic didn't get and receive that medication because the provider was fearful of overdosing the narcotic. So what did they do? They switched to a specific system that did standardized dosing, and at that point in time, narcotic administrations went up and care improved. So if we take that fear out of the provider and we remove that fear, care becomes faster, more efficient, and actually improves and decreases our errors and mistakes.
Yeah, and we propose that we've learned a lot about this inside the hospital systems, and it's not, instead of battling and trying to send everybody back to school continuously, we are identifying what the problem is and setting people up for success. And that is really the way that we should be doing this in the field.
Yep, 100% agree. So now what we look at is human factors, elements. Normalization deviance is a term that has been used in the fire system, has been used in the military, has also been used sporadically in EMS and pre-hospital providers, as well as the hospital settings. It's really took its form in the aerospace and flight. So when we talk about normalization deviance, this is what happens when improper practice, our standards, gradually over time become tolerable. What does it mean? I get away with mistakes. Our job as human beings is to create shortcuts. That's our jobs. Your brain is a giant processor. When we talk about neuroplasticity, its job is to speed up, not slow down. Its job is to cut and fill gaps so it can speed up a task. My task is to deliver medications. I want to be able to do that fast and effectively. That's what the brain wants to do. Well, over time, you develop these steps, these cheats, these cuts. And in doing so, you gradually create a tolerable barrier, a tolerable acceptance of these errors. And what happens is I repeat this over and over and over, and I get what's called deviant behavior. But these deviant behaviors do not have a consequence until it becomes a sentinel event. And that sentinel event then becomes a big issue. And then we go to the provider and go, the provider, it's your fault. But in reality, the system has allowed this to occur. And so normalized deviance is something that we have to be aware of, and we have to be cognizant of situational awareness to increase in its knowledge to understand that this happens every day. So what do we face that creates normalization deviance? This is what we face every single day. We face fatigue. Well, being tired will get us the fast track to create shortcuts. Amplification of distractions. Distractions are one of the things we have to avoid when concentrating and performing a skill or procedure that improves or actually cause harm on patients. If I'm distracted as a provider, how many people are talking to me during the procedure? What kind of distractions do I see in front of me? What kind of environments are giving me distractions? Some of them are in our control, some we can manage, but we want to make sure we limit those amplifications of distractions. Creation of shortcuts, we'll naturally do it. We want to try and fight that tendency. And the big one is the fighting of actually the elevation of human bias. Human bias is one of those things that occurs every single day. It happens in blood pressure assessments. You got a brand new EMT going through their assessments. They don't want to look bad in front of everybody. So what do they say their blood pressure is?
120/60.
Yep. If they're really smart and they knew what they don't want to really be kind of keen on what's going on, they would say 122/78, right? Then you can kind of fight that a little bit. But bias does happen in medicine. And one of the things that this collides to make is this mantra: error is human, no harm, no foul, they meet. And then we get a sentinel event that creates an error that causes poor outcomes. And it's not like one thing caused it. You have to look at medication errors and procedural errors as not a one-time sentinel event, but a global picture that created this event to occur. Where could I have intervened as a system, as an administrator, as a medical director, to then stop and mitigate this so it doesn't get to the sentinel event? Could we have intervened in the beginning, or could we have intervened in the middle, or in the end is where it happened? And that's what you have to evaluate as a system. And as a system, where is the failures? Not just the providers, because it's too easy to blame the providers, much too easy. What we want to do is self-reflect on the system and how we can improve that. And I keep coming back to self-reflection. At this one, when you look at this, ask yourselves deeply, how can I, as an individual, prevent errors? Number one. Number two, how can I, as a crew, prevent errors? Number three, how, as a system, can we improve errors? Because it takes a village. If I make an error and I keep it to myself and I don't tell my person coming in, they're going to make the same mistake I am. So we want to make sure we get these out in the open, which means we have to evaluate the rights. You may have learned it as the 5 rights. You may have learned it as the 6 rights. They're up to 10 or 12 or 13, I think now. We keep adding to the rights. We keep adding and adding and adding. But unfortunately, there's no direction on how to attain this. How do I attain the right drug? Remember, your job is to go ahead and create shortcuts. When was the last time somebody gave epinephrine 1 to 10,000 in cardiac arrest and looked at the box and went through the 5 rights at that time of the event? Hardly ever. Usually when you're first starting out, after the 5th cardiac arrest you ran, it's the brown box. Dextrose, D50. You'll go through your 5 rights during your drug checks. You may do that once or twice in your career. After a while, the drug hasn't changed in forever. So what do? You grab the blue box. You will create these shortcuts that get you into this avenue of the rights. And so the focus of the performance of individuals, that's what this is. It focuses on individual performance. It doesn't evaluate system flaws. And this is what I really love when we're doing our research. The vice president of the Institute of Safe Medication and Practice, Judy Smetzer, she came in and she evaluated these, and she determined right off the bat that this evaluates individual technique, but not system flaws, and it does not provide any useful help at all, guys, to complete them. That's up to us as the individual provider. So if I asked 20 people just randomly, how do you attain the 5 rights? We may get 5 different answers of how they attain it, with no standard process and policy. So again, this evaluates the individual, but not the system. And if the 5 rights, 6 rights, 10 rights, whatever the rights we keep adding works, I come back to the original question we asked. How come there's 1.5 medication errors a year? How come there's 400,000 deaths a year? If they truly worked. And if they do not work, why are we still using them? That's the question that we would ask. And that's how we kind of drove the discussion in the lecture was, is there a better way? That's the question. So with this, are there other options to prevent errors besides utilizing the 6 rights? So if you were taught the 5 rights, 6 rights, 10 rights, are there other ways that you can think of that would be far better? Maybe you're doing it now. Maybe you're practicing now, that you can determine exactly what's going on moving forward.
Yeah, so it looks like the far majority of people, 95% have answered yes to this question. Are there other options? Really happy to hear that, because we don't want to be stuck in an old system that is not working and giving us the results that we want. We want people to be set up for success. Not that you can't be successful in the 5 rights. Right. What we're trying to propose is that it doesn't take into account certain natural elements of the process that we think we can work better.
So if everyone's looking at yes, let's look at the process of potentially improving the system. So looking at this, the first thing we have to ask ourselves, well, what's a medication error?
Yep.
If we don't define the error, how do we know when an error has occurred? So the 5 rights, one of the issues, if I ask everyone on this panel to look at this poll, what most of us are going to answer is it's probably a deviation of one of those rights. That's what we would define as an error. And if we're not doing most of those 5, 6 rights on a scene, then how are we making an error?
That's a really good point. So right now, what we're seeing here is that the majority of people, about 80%, are saying a failure of one of the 6 rights. About 50% are poor patient outcome, and about 40% are CQI team identifies an error. 4% not sure.
Good. And this kind of goes along with what we're finding with the national system that we evaluated is there's not a clear definition of medication error within the pre-hospital world. So I think the first step to identify medication errors is to simply just define what an error is. So looking at this, number one way to improve medication errors is to have a clear and concise definition in policy, in writing, so that way you set up boundaries and you set up lines, right? Providers do really good with boundaries and having a line, know where they can go and where they can cross. If I don't have established boundaries and lines, that provider doesn't know where they can and cannot go. So looking at this, by definition, looking at this, any preventable error event that may or lead to inappropriate medication use or harm to a patient. This, by definition, according to the Center for Medicare and Medicaid and the CDC, is what an error is. So if they're using it, probably a good idea that we would be using it. The things I want to highlight in this definition are 2. Number 1, may. It doesn't say it did. It doesn't say it will. It says may. So if I give a medication or a procedure and I go like this, phew, I didn't cause any bad problems, that's good. And to me, that's not an error because there was no bad harm. But in reality, it is. Because if I don't check that and assess that and evaluate that and let my supervisor know or my officer know and everybody else know about it, then that error is going to continue on.
Yeah, and this is where we'll also put in the concept of near misses, because it's one thing to have completed an error and recognize that you made it. It's a whole nother thing to recognize that there was a near miss that was caught in the process, because those near misses, we're talking about the same concept.
Right.
Why did it happen? And a lot of organizations don't even count near misses because they're not telling people to report them. They're not seeing the importance of those. And they're just as important as an actual mistake or an error, because we can go back and look at what happened within the process.
Yeah, the near miss is real important. The fire system, we've learned real early that near miss reports are crucial in operational response and improvement. In the EMS world, in the pre-hospital world, near misses are hardly ever reported. And one of the things that we've done and what we've tried to focus on is getting those near misses out to everybody and saying, hey, this is what happened, and let's not do it again. And again, it's not about the individual making an error and a mistake. We have to take it off the individual. The more we can take it off the individual and put it on the system, the much easier it becomes to report these near misses and get everybody on the same page. Because if I hide that error, I hide that mistake or that near miss, what's going to happen is I'm not going to make the same mistake because I was pretty close to doing it, but my partner or somebody else will, and we want to make sure we avoid that. The second part of this definition I really want to get to point is lead the medication use harm to a patient is preventable, right? So when we establish something as a medication error, the first thing we want to look at is it preventable? And most of the time, the answer is yes. It's almost rhetorical. But there are times that we can determine that this just wasn't preventable. This was going to happen regardless of the crew, regardless of the system, regardless of the time, because of X, Y, Z. So you want to look at, number 1, how is it preventable? And number 2, anything that may cause harm. Once you have a clear, concise definition, now you can move on. You want to create a culture of safety. And culture of safety is kind of a newer trend that's been on in the last 5 to 10 years about what we can do and establish that within EMS, pre-hospital, and the fire system. And this is an approach where workplace safety assumes that humans, despite their best intentions, want to do the right thing. That's our goal, do no harm. But inevitably, we'll make mistakes. The ideology, when we talk about this process, combined with a robust quality improvement program, helps to assure honest reporting and can limit errors. The clinician must feel safe in reporting, safe and away from fear. Remember what we said earlier, the 2 top answers on that poll were fear-driven. If we can remove the fear, this culture of safety enwraps the provider. Does that mean the provider doesn't have repercussions to their actions? No. There may be some repercussions to action depending on what's identified, but that provider still needs to feel safe to make sure they ensure that they can report these errors and mistakes to a supervisor, to an officer, to a medical director, and to your committee, whoever's running the system. but we have to create that culture of safety. If you do not do this step, your medication errors will not change because they will hide them and they will make sure that nobody will know about them, and then you'll never identify them and therefore cannot fix or improve the system, because that's the ultimate goal. Quality assurance, quality improvement, maintain baseline and improve the system. That's how we do with cultural safety.
Yep, and some people may know this as just culture.
Yep.
That is a coined phrase and very, very widely used. Same concept here that we're going through is that let's not blame the person right out off the bat, because their intentions probably were not to make a mistake. And let's find out what happens within the system that set them up for the error. The only way to allow this to happen is to create a system where people feel safe and people feel like they're doing the right thing by coming and acknowledging that something happened.
Absolutely. So we've defined an error, we've created boundaries, we've set up a safe environment where they can make the report. Now we have to provide encouragement. That's the third step. You got to allow self-reporting, you got to encourage it. You know, thanks for telling me this error. I'm glad you brought it to his attention. We're going to let everybody in the line know so we don't let the mistakes occur again. Please let me know what you could have done to mitigate and avoid these errors. What would you have done differently? You go through your quality assurance step, you go through your quality improvement process, but you want to encourage this self-reporting as much as possible. You want to encourage crew resource management. Having the ability to separate and shed multitaskability is very important. One of the things we found with increasing errors is the ability to one person doing all things. And unfortunately, we can't work in multitask world. We are not very good at it. We can do two things at 50%, we can do three things at 33%, but we can't do two things at 100%. So being able to shed responsibility to providers and creating an outlined role in that call is very important. And the last aspect to encouragement is you want to encourage real life training. You actually want to put real life simulations and scenarios together that have design failures and pitfalls. Okay, they'll make mistakes on their own. That's allowed to happen, but we want to design those failures, those what if scenarios. Okay, and then in those pitfalls, how do we react and adjust to those pitfalls? Those three things are important when you talk about encouragement. Now that you got a defined error, now that you got a safe space, you got a real robust education program that has designed errors and failures, you encourage crew resource management. Now we want to design a standardized process of response. You want to create a standard response if an error happens. What is the statement that we're going to provide if a mistake occurs to the patient, to the family, to the receiving facility? Who does that reporting? Is there a policy in place? Is it the officer? Is it the supervisor? Is it the medical director on behalf of the system? These are things that you have to think about within your agency. And as a provider, do I have a standardized process? That's not the time to put the foot in the mouth and say something that we shouldn't. You want to make sure that's already covered. Next thing you want to have, now that I have a verbal response, I need to have an after action standardized response. For every medication error, for every procedural error, what is my after action? What is the process? What committee does it go to? What review does it go through? What's the after action on top of that? That's the standardized process that has to be created, and that's where the real work lies.
Yeah, and we cannot dictate those thresholds to you, especially the verbal, especially the letting patients know, family members know. We could sit here and talk an entire lecture just about where those appropriate thresholds of reporting are. In our mind's eye, it's a no-brainer and obvious 100% you're reporting to the agency so that we can improve the process through just culture. As far as reporting out to patients, that's something that needs to be set and different thresholds for different organizations and different events.
Absolutely. So now that we have that process lined out and we have a good foundation of what we can do, let's look at the process of repeating these mistakes. So if we're in the call and we're actually engaged in it, some things we want to make sure we do. Number one is we want to slow down. So we live by mnemonics and acronyms. That's what EMS loves. So we're going to slow down. We're going to maintain an elevated situational awareness, looking for potential errors. That's what we want to do. We want to avoid any distractions. Get the distractions out of the way. If I'm a medication administration, that's my job. I want to make sure I get rid of these distractions. Anything that's going to disrupt, disturb, or divert focus from the desired task. And you could put this not just in medication administration, but procedures, questioning, and assessment as well. The last one that really improves medication errors is having a good double check system. Now you can do the double check in two ways. All right, so this is where it seems counterproductive, but it helps with this first step. If I do a double check system, it's automatically going to slow me down, right? It's automatically going to remove the distraction because I'm focused on a double check with another person. And we think that it has to be a medic to medic evaluation. It doesn't. It could be medic to EMT. It could be medic to nurse. It could be any clinician that's available to double check the process. And so this component can be done by either A, having both of you separate out, come up with your calculations and come back, and hopefully you have the same number. If you don't have the same number, somebody's wrong. Or simply, I have XYZ drug, I have XYZ dose and concentration. This is what I'm going to give. Do you agree? Hand it to my partner. They go through the same process. Either way, you want to make sure you're double checking, which is going to force us to slow down. And by doing that, they found in literature and studies that it diminishes errors up to 99%. And I don't know if I'm a betting person, but I love the number 99%. You know, that's a pretty good number that they can put facts on to say, absolutely, this double check system diminishes errors. So if it works in the hospital system and it works in other healthcare provider systems and other areas, why are we not doing it in our system? That's the question that we would pose. And again, we're not here to say what's right and what's wrong, what we should and should not be doing. It's just another avenue. If 93% of people feel there's a better way of the 5 rights, is this the one that works for you? That's the question that we're going to ask. Moving on, in the end, guys, it's all about a choice. Just because it's what we've been doing doesn't mean is what we should be doing. Look for other ways and other avenues. Human nature plays a role in our decisions and our mistakes and errors. Safety is a choice. We want to plan, prepare, practice, and perform all with the purpose to do no harm. If you take this philosophy in play, slow down your procedures, create an avenue of self-reporting, have a standardized response, you'll see your errors diminish and you'll see your care improve in your system.
All right, so the last few minutes here, want to talk about some issues with management of medication and medication shortages. Because in the United States, as I'm sure everybody recognizes, we have rapidly growing frequency of medication shortages. Medications that have been around for decades are suddenly unavailable, or they're coming in different concentrations, different formulas. And this really sets us up for some challenges, especially if the EMS providers are not familiar with alternative treatments, medications, and modalities to replace these medications. There are a lot of things that can cause drug shortages. It can be something as what seems as simple as weather, for instance, a huge tornado that wipes out a facility, which has happened in the past, and then all of a sudden for several months we don't have a medication available. Let's take COVID for example. That's one that everybody can relate to. Manufacturing problems, supply chain problems, lots of finances involved, and lots of rules involved. And so there are many ways now that it's become actually the standard to have medication shortages. And really what this does is it creates one of the most unstable variables in our medical treatment of patients. And we have to learn to adapt to this changing environment in order to provide consistency in patient care. All right, so what do we do for that? We plan, we prepare for this. Okay, we're good at that in EMS, and this shouldn't be anything different. We need to anticipate the potential resource shortfalls, and then also line out all of our possible adaptive strategies. So one of those is substitution. Okay, I'll go through a bunch of these very, very quickly, but I think that all of these will sound logical. Substitution is basically using a functionally equivalent medication. We usually want to try to do this by identifying alternative in-class drugs for usage. And we also, one of the reasons that we want to be able to do this is so that we're not needing to hoard drugs in the anticipation of one disappearing, but that we understand that there will be potential substitutions. If we go to substitutions that are not even in the same class, for instance, then we end up with potential larger issues because of the increased provider education and differences in administration. But sometimes we're going to have to do that. We're going to have to leave a class of drugs. So it's not just as simple as, hey, we ran out of Valium and now we're going to use Versed. It's we ran out of an opiate and now we're going to use a drug that has totally different mechanism of action. All right, but it is going to happen and we need to know. One way that we can deal with the drug shortages is by conservation, placing some restrictions on the use of the medications. You can accomplish this by tiered utilization, be it by giving priority to certain types of patients in their medical necessity for the particular medication. Also, discontinuing use of medications that have debatable utility. I think that everybody out there can recognize that there is some room for movement there. Yes, we've always done this, but does the evidence show that we really need to continue to do that? And is it helping 1%? Is it helping 100%? Is it critical in our treatment or not so much? Okay, or adjusting the dosages. This is a time that you all have to figure out, hey, if we gave half the amount of that drug, is it going to accomplish the same thing? All right, these are questions that some people in organizations never needed to ask in the past. Reusing medications. Now, I'm not saying once you've given a medication, you've used it and it's no longer available to reuse. However, a lot of the equipment that comes along with the medications may be able to be cleaned, disinfected, sterilized, and used again. And then we'll also talk in a minute about multi-dose vials. We can reallocate the medications, as I said, using certain medications on a priority for the people who really need it, and the people who are going to have the best chance of actually having a better outcome based on giving that medication. And we have lots of examples of being able to do this. These are all adaptations. Here is a mitigation algorithm from a certain organization that basically, if you look at the contingency column, you can see that it goes on the left-hand side, it goes from 1 to 7, 7 being the crisis mode and 1 being normal. Okay, and as you go down the contingencies, you can see you don't need to do anything initially. And then they're gonna start utilizing expired medications, but the same medications. And then they talk about maybe using compound medications. And then they start figuring out, do we really need to use it? Is there a same drug equivalent same mechanism of action drug that we can use? Or do we have to then move to a completely different medication? And then sometimes dealing with not having the medication at all, potentially in crisis. And so these are examples of coming up with a strategic plan about how you will deal with tiered medication shortages. Expanding the expiration dates. This is a big question. I do not have the exact answer for you about how long a drug remains efficacious. Some of the companies have their understanding of how long the drugs can last, and that's why they put the expirations on them. The FDA does not decide this, but definitely has part of the conversation. And we all are going to be faced with using medications that are expired. Do we throw it away because it's 1 day past the expiration date? No. But are there certain drugs that we know are less effective fairly quickly after the expiration date? Yes. We'll say albuterol is one. Nitroglycerin is a quintessential one. But there are plenty of other ones that probably remain with a large percentage of their efficacy far after their expiration date. And is it better to have a drug that you know that you may not have a replacement for, even of a different class, and still use it, even though it says that it's expired, or not using it at all? Those are all questions that we need to be able to ask. Sharing resources. You don't have to operate in a silo. You can share with other agencies, with hospitals. Sometimes it's difficult to keep tracking and the responsibility of tracking those drugs, but that sharing with different facilities, especially from the hospital level to EMS and back and forth, can really help in times of medication shortages. And then let's talk about sparing here. We're dividing out multi-dose vials of medication to treat more patients. What can it do? Well, it can certainly reduce waste. One of them that comes to my mind immediately is ketamine, which comes in these large vials, and we use these extremely small amounts for pain management. And you could treat 30 patients on one vial of the ketamine, yet we drop one and then we toss the rest of the bottle. And so figuring out ways to divide those medications out and then use it for more patients. That is not as easily done as it is said, especially if it is a restricted medication or a scheduled medication. You're going to be dealing with potential increased diversion. Medication tracking becomes an issue. Willingness of pharmacies to divide those medications out, or do you take that responsibility as a agency? Those are all questions, but sparing is definitely something that we all have to consider as we move forward. And what I'd like to ask here is, do you as an agency divide out multi-dose vials to reduce wastes? Okay, and as those numbers come in, our anticipation is that the far majority do not. And it looks like here we're about 80, about 90, 10. So 13% said yes, 88% said no. And that's about exactly where I thought we were going to be with this. And it's something just to keep on the back burner and really recognize that, that we are going to need to figure out how to do that in the future for waste reduction, especially when all of a sudden you turn around and your top 3 drugs are no longer available. One more minute here. I'm talking about compound medications. We don't have a lot of time to talk about this, but it is a theoretical way of getting medications that don't go under the same rule process as non-compounded medications. And some agencies do use compounding medication pharmacies in order to get their supplies, especially in times of shortage. And really the bottom line here is that the day and age of relying on the consistent availability of medications is over, and it probably is not coming back. We can expect it probably to get worse. And we really do all need to come up with multi-tiered plans for adaptation to the drug shortages in order to provide good, consistent patient care.
So in the end, everything's changing.
Yep. The only consistency is inconsistency.
That's the end of our lecture, guys. I hope you enjoyed it. I think we have some time to answer any questions. Be happy to answer them. If we don't have the answer, we'll definitely find one and get one to you. And hopefully we can get all your questions answered either now or at a later time. Again, appreciate everyone's time.
Yes, thank you, Mark and Dr. Bronsky, for sharing this vital information today. Throughout the webinar, as Mark mentioned, we have been collecting participant questions. We would like to take this opportunity to go through some of them. And as a reminder, we may not be able to address all of your questions today, but we will provide replies to unanswered questions on our website along with the recording of this webinar. Our first question, Mark, do you recall the name of the 2000 study you mentioned of California paramedics self-reporting medication errors?
So that was done in San Diego in 2007. So if you search 2007 San Diego medication error study, you'll find it.
Great, thank you so much. Dr. Bronsky, can you comment on service budgets? Some agencies are no longer carrying certain medications because of budget cuts.
Yeah, so that's a really fantastic question, and especially in this day and age when I imagine most of us are scrutinizing our budgets a little bit more carefully, this is a time that you really do need to go and ask, are we going to continue doing or using a certain medication just because we've always used it? We really need to analyze all the medications we use and figure out and answer a couple of questions. One, is this truly something that is going to make a difference for the patient? And two, is it going to make a difference for the patient in the time frame that we have them in our hands as EMS? I would venture to guess that there are a lot of medications out there that we would answer no to at least one of those. And that is a time that, this is the time that you need to say, well, then maybe we have to go without certain medications that aren't as critical.
And I think to add on that a little bit is that a self-evaluation of, do we need to carry 3 medications that do the same thing? You see a lot of agencies carrying multiple medications that can do a lot of the same thing, and you end up wasting more medication than using because we just don't ever get to that, 3rd tier, 4th tier narcotic or, other things.
Or antiemetic or arrhythmic or, anything like that. So very good point, Mark.
Thank you. I think we have time for just one more question. Is there research on the use of CBD or THC in the field as an alternative pain management other than narcotics?
That's a good question.
Yeah, that's a
didn't
good
see that.
question, and didn't see that one coming, which I should have, considering that we're in Colorado and have had a lot of experience with marijuana. I think that the answer to that question, I can confidently say, is very much still debated. I do not think that there is clear evidence that has swung the pendulum and landed it firmly on one side or the other. You can definitely find research papers and the such that tout that it really does help, and others that say that it doesn't. I can tell you that we don't use that as a system, although we are familiar with our population using that for pain management. I wish I could answer that better, but I think universally, and watching that subject pretty closely, we do not have the answer to that at this point.
And I would venture a guess with the variability of manufacturers and productions of that medication is so widely dispersed that getting a consistent medication, that CBD, to even drive that study would be difficult. You'd have to have a standard that would be approved by everybody. But that's a good question.
Thank you again, Dr. Bronsky and Mark, and thank you again, iSimulate, for sponsoring today's webinar.